special interest in pediatric ophthalmology, strabismus, and neuro-ophthalmology, and has done fellowships in Boston and Minneapolis. And today he's going to be talking about do's and don'ts when assessing a child with nystagmus. Thank you, Dr. Helbig.
Thank you, Dr. Sharma. Today I'm going to discuss what to do and what not to do, and these are just suggestions from my side. You don't have to stick to what I'm saying, but I want you to just understand one point. If there is anything to take from this presentation, nystagmus is not a diagnosis. Actually, it's an initial step in your diagnostic process. So there is no patient that should go out from your clinic with a diagnosis of nystagmus. Okay, oops. Just a second. So these are two patients with very similar nystagmus. Horizontal nystagmus, right beating in the right gaze, left beating in the left gaze. Horizontal and up gaze. Both patients, they have totally two different diagnoses. Their vision, the patient on the right side has a counting finger vision, while the patient on your left side has a vision of 20/30. So we're not dealing with nystagmus. You have a patient with nystagmus. You don't have a patient with a diagnosis. You have a patient with a finding. So first thing that you shouldn't do is do not panic. Again, people, when we see a patient with nystagmus, we start to think about brain tumors. And this has been looked at before. And just to reassure you that they looked at almost 300 patients with nystagmus, and brain tumors were only found in less than 2%. So when you're dealing with nystagmus in a child, most likely, you're dealing with an eye problem, something that you can diagnose. You don't need to do anything for it except your usual workup. So take a detailed history. You have to take a detailed history, and the three elements that I usually look for is the sensitivity to light, the variability in the vision between the daytime or night, and lastly, the history of nystagmus, poor vision, or easily a sunburn. These are the three elements that I usually screen for when I see a patient with nystagmus. Don't overlook the pupil. The pupil can tell you a lot about the diagnosis. This is a child with retinal dystrophy and sluggish reaction to the light. This is another movie. It's a retro, very old movie, but it shows you a paradoxical constriction of the pupil when the light's dim. You can see that here. And the next thing is check ocular structures. As you've seen, not from just nystagmus, there's a lot of presenters who presented very interesting cases, and the diagnosis was made based on history and proper examination. So look for findings in the eye that can explain the nystagmus. Aniridia, transilluminations, fundus changes, especially when you're dealing with albinism. Remember that they have a classic optic nerve findings. I'm sorry, I'm not showing it here in my slide, but you have to look for it too. Foveal hypoplasia, if you have a patient who can sit for OCT, optic nerve changes. And when I'm talking about optic nerve changes, I'm talking about optic nerve hypoplasia, aplasia, optic atrophy. You have to look for these. And in prior presentation, I've just said that use the direct ophthalmoscope. It gives you a detailed view of the optic nerves. The indirect does not. So try to use the direct through a dilated pupil. That gives you a lot of information. Another thing is look at the blood vessels, the retinal blood vessels, the arteries. If there is any constriction, are they attenuated blood vessels? If these are attenuated blood vessels, start to think about retinal dystrophies, early changes in retinal dystrophies. So proper examination, paying a lot of attention to details can save you a lot from this workup standpoint. This is the view of the optic nerves, and actually I will show you the patient who has these findings in the next few slides. Check refraction. This is really intuitive. You don't have to think about it. This is what you should do for every patient coming to your clinic. Whatever he has, nystagmus is a finding. You would do it, the same thing, you will do it for strabismus. Don't overthink about it. So check the refraction. If you have a patient with myopia, start to think about congenital stationary right blindness and other differential hyperopia. Start to think albinism and Leber's congenital amaurosis. check for strabismus, positive angle kappa, you start to think about albinism. So shine a light with a muscle light and look at the reflexes and think about albinism. And this is what I want to show for this picture is just to show the DVD. And because the most sad story when you see a patient with manifest latent nystagmus sent for neuroimaging for things that you can easily pick based on history of strabismus or based on your examination. For this patient, she has manifest latent nystagmus, but she has a DVD that can tell you this patient has this for a long time. She doesn't need any imaging. And the last and most important one, don't request neuroimaging in a child who is neurologically normal. The last slide will show the indications, but I will going to go quickly through different videos. Actually, I will stop at this study. This is a study that looked at acquired nystagmus in 10 patients as a presenter of intracranial tumor. All of the 10 patients had optic atrophy. So the imaging was done because of the optic atrophy. The diagnosis was done based on the optic atrophy, not based on the nystagmus. The study that we looked at earlier, the 300 patient, the first study utilized by physicians, by ophthalmologists, was the MRI. And it's, as you can see, it's the lowest yield. So don't rush for MRI. Just do your proper examination and then think about your differentials. And it's not surprising that the highest yield test that you've done to your patient is the eye examination. This is where you can make your diagnosis. It's not the MRI at all. So when do we need to image? I'll just go through quick videos. This is actually, it's a video on the AAO website showing what they listed as spasmus nutans. I would say it's very unclassical. The patient is young, he's 4 weeks old, so it's not classical one, but you can see the head oscillations, the monocular nystagmus in one eye. This is not the point what I'm saying, that we definitely need to do neuroimaging for this patient, but I just want to just shine the light on one thing. These patients might have retinal problems. So if you do the MRI and it's normal, start to think about retinopathy. You don't rule it out just by doing the MRI. Second patient, and I'm showing this video because this is the patient that I want you to look at. Look, when we cover the left eye, the nystagmus is beating toward the abducting eye. So left beating when you cover the left eye, right beating when you cover the right eye. This is classical for latent nystagmus. Again, if anything, these patients should not get any neuroimaging. This is a clinical diagnosis. This is the patient that I just shared with you, his fundus photos, and shows the optic nerve changes, and you can see the upbeat nystagmus. The reason that I'm showing this, that instead of what you think about adult patients, when you think about brain anomalies causing the upbeat nystagmus in younger children, it is most likely the anterior visual pathway. So retinal disease can cause this. You still have to do it. You still have to check the retina. You still have to check the optic nerve before sending the patients for imaging. And this is the last patient with ocular shiver, and this is a patient that you also need to send for neuroimaging. And just in your differential, keep opsoclonus, neonatal opsoclonus, which is a benign condition, in your differential. Again, this is the last slide, and it shows the indications, my suggested indications for neuroimaging in nystagmus. So it can be based on the nystagmus finding, can be based on the associations. And this is the list of do's and don'ts. Thank you.